Rahman Rahim. Thank you, Mr. Chairman. In this presentation, I'm going to discuss the pharmacological treatment of HFrEF in patients with CKD. And when we face these phenotypes of patients, we have some worries regarding the occurrence of renal problem after introducing the ACI or ARBs. Patient may develop acute kidney injury or hyperkalemia. Also, these types of patients are underrepresented in randomized controlled trial. So there is uncertainties regarding the response to GTMT compared to the non-CKD patients. And every day we have this difficult discussion between cardiologist and the nephrologist about the merit of GTMT in CKD patients, and sometimes this conflict is hard. And in this unique accident, the police arrested a doctor on a conflict upon the management of the patients. These were a nephrologist and a cardiologist, and they were in conflict regarding the introduction of diuretic in a patient. And in this time, the police arrested the nephrologist. This is a common problem among heart failure patients. We can detect CKD in up to 1/3 of patients, and it is associated with worse outcomes. The lower the eGFR, the higher the mortality and heart failure hospitalization. And among heart failure patients with CKD stage 4, the risk of heart failure hospitalization and mortality increased up to 2-fold compared to stage 1. And also, patients with CKD had 4-fold increased risk of heart failure. Actually, the major cause of death among patients with CKD is cardiovascular causes rather than renal-related causes. This is because CKD and heart failure share many backgrounds in terms of abnormal hemodynamics, neurohormonal mechanism, and underlying causes such as diabetes and hypertension. And when we look to the pillar of management of heart failure and pillar of management of CKD, they share many pharmacological agents. They share the ACI, the ARBs, the MRA, and the SGLT2 inhibitors. So when we are treating heart failure patients, we are improving the kidney function. And vice versa, when we are treating patients with CKD, we are preventing heart failure. So we should not look to heart failure and CKD as enemies. Actually, they are friends. And when we treat a patient with CKD and heart failure, we can categorize these patients into 4 types of patients. Those with non-severe CKD, stage 1, 2, 3. Those with severe CKD, but not in dialysis yet. Those on dialysis, and those who develop acute kidney injury when we introduce GTMT to those patients. I'm going to discuss the guidance for management of these patients in the following 10 minutes. To start with, those patients with heart failure and eGFR more than 30, stage 1, 2, or 3. Luckily enough, the landmark pivotal heart failure trial recruited many of these patients. The ARNI excluded patients with eGFR less than 30. The same with the SGLT2 trial inhibitor trials. MRA excluded patients with serum creatinine more than 2.5. And we have a different cutoffs for serum creatinine between 2 and up to 3.4 in beta blocker ACI and ARBs trial. So we can extrapolate the results in the non-CKD patients into those with stage 1, 2, and 3 CKD numbers. For example, in beta blocker, as we can see here, patients with stage 1, 2, and 3 had the same relative risk reduction in terms of all-cause mortality, death, and heart failure hospitalization. But actually, the relative risk reduction is lower when compared to those with non-CKD. But the absolute risk reduction is higher because those patients are at increased risk. So the number needed to treat to prevent a harmful effect among CKD patients is lower compared to non-CKD patients. The same applied to the trial of ACI and in ARNI. In ARNI, you can go for 30 ml per minute eGFR. And in MRA and SGLT2 inhibitors, actually those with lower EGFR had maximum benefit compared to non-CKD. The relative risk reduction in cardiovascular death and heart failure hospitalization may reach up to 40% with SGLT2 inhibitors. So the message here among those common type of patients, they have at least the same, maybe higher than the benefit compared to non-CKD patients. Now to another challenging group of patients, those with severe CKD, EGFR less than 30, but not yet on dialysis. These patients are excluded from all trials except with two agents. One, SGLT2 inhibitors, namely empagliflozin, because the EGFR exclusion is less than 20, and Versaquat. In the Victoria trial, the exclusion criteria was EGFR less than 15. However, the data in the other groups are limited because they are derived from observational trials with many bias, and because of the conflicting results, there is no clear beneficial effect in these patients. However, there were no signal of harm. And the message here, we can use GTMTs in patients with stage 4 and 5, not yet in dialysis, with cautions, with serial monitoring of serum creatinine and potassium. The strongest evidence in this group of patients is related to beta blocker. And in this upper study, recruiting about 6,000 elderly patients with heart failure, those who used beta blocker had lower mortality compared to those without beta blocker, with EGFR less than 30. And however, on the other hand, in this lower meta-analysis of 10 randomized controlled trial in patients with ejection fraction 50%, those with EGFR less than 30 did not derive a mortality benefit. So we have a conflicting data. However, the majority of evidence is related to a benefit. Of course, empagliflozin is associated with benefit across the whole range of EGFR down to 20 milli per minute. Now to a more complex situation, heart failure and dialysis, HFrEF with dialysis. And this is an important category because up to 50% of those end-stage renal disease patients do have different phenotypes of heart failure. And when those patients die, in 50 to 60%, they are dying due to cardiac cause, including heart failure. Again, we do not have adequate evidence from randomized controlled trials. But again, we have very strong evidence for beta blockers. To the left, we have this retrospective study that matched 1,070 patients, heart failure on dialysis, using beta blocker to non-user of beta blocker. And as we can see, over a period of 5 years, there was 20% reduction in terms of total mortality. And there was no difference between any type of beta blocker, long-acting metoprolol, carvedilol, or here it was bisoprolol. To the right side, we have a unique randomized controlled trial, Italian trial, that randomized 114 patients to carvedilol versus placebo, heart failure patients, on dialysis. And there was dramatic 50% reduction in mortality over 2 years. The evidence for ACI and ARBs is conflicting. To the left side, we have data from Taiwan that showed 20% relative risk reduction in mortality in dialysis patients with heart failure when they are using ACI or ARBs. On the right side, from the Minnesota Heart Survey trial, these drugs did not show benefit among patients on dialysis. And these KDIGO recommendations, as you can see, give a strong recommendation for carvedilol in dialysis patients with heart failure, weak recommendations for ACI and ARBs in patients with heart failure, and of course, MRA and digoxin are contraindicated in those type of patients, despite the presence of one single trial or observational data that should improve survival in heart failure patients on dialysis receiving MRA. Can we use ARNI in patients on dialysis? These are very common hot questions. Initial data showed improvement in quality of life and ejection fraction when we are using ARNI in patients with heart failure on dialysis. Later on, we have this study that showed increased heart failure hospitalization and the composite of mortality and heart failure when we are giving ARNI to patients with heart failure on dialysis. And only last once, we have this meta-analysis of 26 study recruiting about 2,500 patients that showed improvement in the ejection fraction, and this was the primary endpoint. But on the other hand, also it shows improvement in total mortality when we comparing ARNI in those patients compared to the conventional treatment, but strangely enough, this was not associated with improvement of heart failure hospitalization. So why did this patient had improvement in mortality? There was no increased risk of hypotension or hyperkalemia in those patients. Finally, when we introduce GTMT to a patient with CKD, we are expecting some rise in serum creatinine, acute kidney injury, defined as increase in serum creatinine more than 0.3 milligram per deciliter or 1.5-fold increase in serum creatinine. And this is a common situation. Up to 50% of patients with acute decompensated heart failure may have worsening renal function on hospitalization. This is common with ACI and ARBs, less common with MRA, less and less common with GLA2 inhibitor, and very uncommon with ARNI because of some hemodynamic changes within the glomeruli. And it is important to have the concept that this transient drop in ejection fraction is small and it is transient. Actually, it will recover within few months, up to 1 year. There is no nephron loss. It is just a changes in the hemodynamics. So there is no increased risk of progression of kidney disease. Actually, it is renoprotective. And it has no impact on the favorable outcome of these drugs on the cardiovascular endpoints. So it is called pseudo worsening of renal function. The problem comes when physicians discontinue or de-escalate these medications. This discontinuation is associated with increased mortality in those type of patients. And actually, when we continue on ARNI, and specifically on GLA2 inhibitor, the rate of decline of eGFR in those patients, despite this initial drop, improves. May I have 1 or 2 minutes to discuss this? Okay. So what to do when we are giving GTMT to heart failure patient and there is worsening of the renal function? If the rise in the serum creatinine is less than 50% and up to 2.5 milligram per deciliter and the serum creatinine less than 5, continue. If the serum creatinine is more than 3.5 or there is doubling in the serum creatinine or the potassium is more than 5.5, discontinue. In this situation, then re-challenge again. This is true for the ACI, for the ARP, and for the MRA. But in MRA use, we discontinue with serum potassium more than 6, not 5.5. For the SGLT2 inhibitor, it is very unlikely to have hyperkalemia with these agents, very unlikely to have significant rise of serum creatinine with this agent. Search for other cause. With beta blocker, there is no impact on serum creatinine. When there is rise in serum creatinine with beta blocker, expect poor survival. The ejection fraction is going down and the hemodynamic is deteriorating. This is the main cause for lower ejection fraction on beta blocker treatment. The same occurs when we introduce diuretics, especially in patients with acute decompensated heart failure, and strangely enough, when the serum creatinine rise, the prognosis is better as long as there is decongestion. So continue diuresis despite the rising of serum creatinine. In the doses trial, it shown that giving diuresis during hospitalization with improving in the serum creatinine is associated with worse outcome. So we should have a dissociation between the changes in serum creatinine and the outcome, and this should not influence our decision to continue the GTMT. So continue diuresis with close monitoring to the natriuresis and urine output, not to the serum creatinine. And do not stop other GTMT. Actually, the presence of GTMT in those patients with worsening of renal function improve diuresis. This is true for ARNI, this is true for ACI, and this is true for MRA. This is my final slide. When we're treating patients with CKD and heart failure, we are not treating numbers. We are treating patients with poor prognosis. We do not have a disease called hypercreatinism. We have a patient with heart failure, with some changes in his chemistry, with very high risk for mortality. So do not stop or de-escalate GTMT in those high-risk patients. Thank you for your attention.